Good afternoon, and welcome to Infectious Disease Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests has been mitigated. If you have a question for our presenters today, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please submit it into the Q&A chat. A link to the event survey will be shared at the end of the program. It is now my pleasure to introduce Dr. Supriya Mannepalli, Medical Director, Infection Prevention and Control.
Thank you. Good afternoon. Thank you for attending the ID Grand Rounds. Today the topic is practice changes related to infectious diseases and some updates from the ID Week 2025. We have Dr. Merin Varghese and Dr. Barry Bonds joining us today. And Dr. Varghese attended medical school at Medical University of Americas and did her residency at LSU Health System. Her infectious diseases fellowship was completed at Medical College of Georgia. She joined NGHS in October of 2018. She's an NGPG infectious diseases attending physician. Barry Bonds is a board-certified infectious diseases pharmacist. After graduating from Duquesne University in Pittsburgh, Pennsylvania, he completed his PGY1 residency at the University of Virginia Health System. Dr. Bonds started his pharmacy career at Dartmouth-Hitchcock Medical Center, practicing critical care, then transitioned into infectious diseases in 2010. He joined Northeast Georgia Medical Center in 2016. He serves as the pharmacy specialist for the antimicrobial stewardship program and also the program director for the NGMC Pharmacy Residency Program. Please join me in welcoming Dr. Merin Varghese and Dr. Barry Bonds.
So all three of us actually attended ID Week, which was held in Atlanta this year. And, there were several takeaways from that. From the meetings, but we chose a few topics that we felt that would be pertinent for all of you that are present. Again, thank you for having us today. If I could remember to do this. Yes, it's working. So there are no disclosures. I am going to talk about duration of antibiotics, specifically shorter is better, focusing on that. I'm going to talk about skin and soft tissue infections and urinary tract infections because, ID being as broad as it is, we can't squeeze all the topics that we want to onto our presentation. So these two are I felt are high yield as far as discussions. So why do we need to focus on duration of therapy, especially for antibiotics? It is important to focus on that because longer treatment courses has been shown to be associated with antimicrobial resistance, and focus on duration of therapy, or DOT, is one of the most commonly implemented antibiotic stewardship strategies. It has been shown to be safe. It's widely accepted as well. No data actually support the notion that longer course actually reduce the emergence of resistance or that relapses lead to resistance. The longer you put a patient on antibiotics, there's increased risk of antimicrobial selective pressure, and it leads to likelihood of resistance. And a lot of the durations that we use for antimicrobial therapy are actually from expert opinion and tradition that have very low evidence. And at some point, we were concerned that if you don't treat them for a longer period of time, or if they don't finish the 14-day course for pneumonia, then that could lead to resistance. In other words, short course may lead to resistance to the antibiotics. And this was practiced despite knowing that we overtreat patients and that, but regardless, we want the patient to be maximally cured. So Dr. Paul Sachs is an infectious disease physician, and he wrote a satirical piece in the New England Journal of Medicine blog highlighting the lore in figuring out the length of antimicrobial therapy. It's based on non-evidence, it's using non-evidence-based multiples of 5, because you got 5 fingers of hand, or 7, just the days of week. So he said, how long should somebody be put on antibiotics? So he said, choose multiples of 5 or 7. If it's an outpatient problem that's mild, choose something that's less than 10, but make sure you're using multiples of 5 or 7. Is it really mild? So that the antibiotics probably aren't needed at all, but patient or your doctor are insistent that patient needs to be on antibiotics, just break the 5 to 7 rule, and just put them on 3 days of antibiotics. So there's, several things that he noted on there. What I found interesting was that, if the infection involves the bone, 4 weeks or 6 weeks, just get rid of the 5 and 7 rule here. So it's really, even though it is very satirical, it's really because no one really had a lot of evidence as to why do we do what we do. It's almost as though it's anecdotal, right? Why we are using 5 days versus 7 days. And if you think about your own practice, skin or soft tissue infections, we'll do like 5 days, maybe 7 days, maybe we do 10 days. Do you ever put somebody on like 12 days of antibiotics? No, right? It's like they got to do a 5 or 7 day or 5 to 7 multiples. So segueing into skin and soft tissue infections, this is actually from the Infectious Disease Society of America guidelines. It's actually pretty old. It's from 2014. And so this is, there are several presentations. So for impetigo or ecthyma, most commonly, it is Strep pyogenes or Staph aureus. You can do a maximum of 7 days. You could definitely consider a shorter course if there's a rapid response. If there's the erysipelas or if there's non-purulent cellulitis, most common pathogen is Strep. And you can consider about a 5-day course. And in certain people, like those with lymphedema, those with underlying vascular issues, you may want to consider a longer course, but most people would respond to a 5-day course. And the reason why I kind of highlighted the typical pathogens is that when someone's coming in with cellulitis, it is also important to think to yourself, do they really need that pseudomonal coverage? If they don't have an open wound, if they don't have type 2 diabetes, if they're not immune compromised, and they're here with cellulitis that's not improving on outpatient therapy, you probably can get away with using these agents, agents that cover these organisms. Like cellulitis does not need cefepime, That's too broad. So this is another reason why this slide is here to, to kind of tell ourselves that these are the most common agents that we need to treat. They have recurrent abscess, or if they have purulent abscess, which is Staph aureus, if they have had, IND, if they have had incision and drainage, you can get away with a shorter course of antimicrobial therapy, 5 days or even less. IDSA actually recommends no antibiotics if the abscess is less than 2 centimeters and if they have had appropriate incision and drainage. They have had recurrent abscesses, 5 to 10 day course. Decolonization is recommended. And of course, if they have had an abscess and if they have had IND, you can tailor antibiotics based on cultures, if we could ever get cultures. Wound infection, maybe a mixed flora, 5 to 7 days if short duration, if a good source control is obtained. Infected ulcer or chronic wound. They say 1 to 2 weeks if there is evidence of infection. And this is, it's a very I don't want to say complicated, but it's a very common scenario that, in fact, as ID folks we see, where someone has had a decubitus ulcer for years. They have an open wound for several years, and they're malnourished. They're they're bedbound, and they have low quality of life, poor nutrition, etc. And oftentimes we get consulted for these sacral decubitus ulcers, and that are open for several years, and we can't fix those with antibiotics, So that's why often we say, there's no role in IV antibiotics, because even if they have sacral osteomyelitis, you don't have one source control, you don't have good wound management, you don't have good nutrition. Oftentimes we treat it like a skin and soft tissue infection, and oftentimes we may do anywhere from 5 to 10 day course of antimicrobials. And we always say, if it is an open wound, and if there's no signs of peri-wound erythema or peri-wound infections, do not swab the wounds because you will get organisms that are colonizing the wound, not necessarily an organism that actually is causing an infection. So if you wanted evidence as to why, we are recommending all this, the recommended duration of antibiotics, here they are. There's much more, but there's some. This is a patient. He is 21 years old, 22 years old. He is a ranger. He's in the Army. He came to one of our ERs because he had left arm swelling and pain. He was seen in the ER. It was one of our sister facilities. And they did imaging. They didn't find any gas there. It's just soft tissue swelling. And then he was transferred to our facility, in Gainesville, within a few hours for plastics or hand surgeon consult, because he had pain, and he had increased swelling while he was in the ER as well. So I saw him the next day, about 16 hours after this picture was taken. So I walk into the room, and this is not a complete picture, but you can see the bullae there. You can see the erythema here. This was actually tracking all the way above his above his elbow as well, and he had considerable amount of pain as well. And he was before he was transferred to Gainesville, I was called to give antibiotic recommendations. So I put him on vancomycin, I put him on linezolid, and another antibiotic as well. I believe it was Amsulbactam, if I'm not mistaken. His white count was 24 or so. So anyway, so I saw him in significant amount of pain, and more swelling as well. So ended up calling the plastic surgeon who came to bedside within a couple of minutes, and he was taken to the OR. And this is the next day when, after debridement, when they opened up the dressing. So, these Army guys actually come to Dahlonega for ranger training, and we have had several of them who come in with upper extremity infections. On the other side, he actually had, or maybe it was here, he had a small little puncture wound from just being out in the woods. A lot of times they just keep an eye on it. They don't really seek care immediately. But anyway, so intraoperative culture showed group A strep. So this was neck fash. I called the plastic surgeon as soon as I saw that, and I said, he has neck fash and he needs to go to surgery. So basically, but he was in our hospital for almost a day without any surgical management. Just on antibiotics, and as you can see, as I told you, he was on broad spectrum antibiotics, and despite that, this progressed. It goes on to show you what the importance of source control and timely surgical management is. So, this is a career-changing diagnosis for him. he will never go back to being in the Army. He's going to be dismissed. So I can't say that it could have been prevented had he had earlier surgical intervention. It's always hindsight's 2020. But if you ever have somebody with concerns for rapidly progressing soft tissue infections, it's very important to do a physical exam because his arm was swelling up throughout the night, but no one was notified. So, and he didn't let anybody know either. So at this point, the takeaway is that you have rapidly progressing infection, you call the surgeon right away. It's very important to do a very detailed physical exam to see, where the erythema is tracking to, and if it is tracking up. I mean, his erythema was actually tracking up as I was in the room. I spent about an hour in the room until he went to the OR. So it's just very, very important that we do a good physical exam, and when we have a high suspicion for an infectious process, to at least to ensure that there's a surgical consult right away. So we had to actually transfer him to Walter Reed, where he would get hyperbarics therapy and more intervention. He had 2 debridements here, and we finally managed to arrest the necrosis here. So I don't think he needed more intervention since he went to Walter Reed's. But 22 years old. Wouldn't be a presentation for skin and soft tissue unless I shamelessly plug Linnaeus Lid. I like Linnaeus Lid. There have been, and anyone who's rotated with me as a resident, and other ID docs here as well, I'm sure you have seen necrotizing soft tissue infections. And over the past several years, what we've noticed is that there's been an increased resistance to clindamycin with the group A strep. So when there is a necrotizing soft tissue infection, and when I want to add antitoxin therapy, I use Linnaeus Lid, granted that there are no major contraindications, and there are, no drug-drug interactions that could be fatal, I guess. We have safely used Linnaeus Lid in those who are on concurrent SSRIs as well. I've never had a patient who have had serotonin syndrome as a result. So if you're suspecting a necrotizing soft tissue infection, if you're suspecting an early, gas gangrene, et cetera, Linnaeus Lid is a good choice. So next, we'll segue into urinary tract infections. So our previous guideline, we have a new guideline from the IDSA from 2025. Our previous guidelines were from 2010, so way overdue. So our old classifications for urinary tract infections, so we had the uncomplicated UTI, acute pyelonephritis, and then the rest were all complicated UTIs. So uncomplicated UTI was, per old classification, acute cystitis, afebrile, non-pregnant, premenopausal women with no diabetes and no urological abnormalities. And then you have your acute pyelonephritis, acute kidney infection in women, otherwise meeting the definition of uncomplicated, UTI above. All others were considered complicated UTI. The new classification has is, I guess, probably makes more sense than the old one. The new classification, there's uncomplicated UTI, so infection that is confined to the bladder. So it's like your cystitis in afebrile men or women. In the past, UTIs in men were all considered complicated UTI, not the case right now. For the new classification, and the complicated UTI is infection beyond the bladder. So anything that's not cystitis. There's pyelo, there's febrile or bacteremic UTI, catheter-associated UTI. Prostatitis was not covered by these guidelines because they often need much longer course of treatment. So basically, we talked about what complicated UTI is. It's associated with fevers. The infection is extending beyond the bladder. There's evidence of systemic illness, chills, rigors, hemodynamic instability, there's flank pain, CVA, costovertebral angle tenderness. So pyelonephritis is a complicated UTI. And another classification is UTI with symptoms associated with transurethral, transpubic, intermittent catheterization is also considered complicated UTI. So if they have a indwelling urinary bladder, neurogenic bladder, urinary obstruction, urinary retention, these are all considered to be complicated UTI. Uncomplicated UTI, is basically you have local bladder symptoms and signs, dysuria, urgency, frequency, suprapubic pain, but they have no signs of, they have no CVA tenderness, they have no fevers, they have no evidence of systemic illness. It can occur in males or females, even those with underlying urological abnormalities, those who are immune compromised, those with diabetes. Recurrent UTI can also be uncomplicated. Those with urinary catheters, as we discussed before, has complicated UTI. So what's the duration of treatment? Those with complicated UTI, including those with pyelonephritis or those who are bacteremic as a result of complicated UTI, the society guidelines is to treat with a shorter course of antibiotics, which is 7 days, rather than the traditional 14-day course of treatment. If you're using a fluoroquinolone, you may be able to get away with a 5-day course. Again, that granted that the patients are systemically well and are otherwise doing well. Prostatitis likely will need much longer. In my experience, we've had to treat for more than 14 days, more like 4 weeks, because they have such protracted course. And I know Barry's going to talk about oral switch versus IV in his slides. But like we talked about, the complicated UTI, febrile UTI, pyelonephritis, CAUTI, bacteremic UTI, 7 days is sufficient. And for uncomplicated UTIs, the antibiotic choices, you could use nitrofurantoin, you can use Bactrim, you could use fosfomycin, fluoroquinolones, beta-lactam, fibmecylinum. For nitrofurantoin, 5 to 7 days. Bactrim, 3 days. Your fluoroquinolones, 3 days. Beta-lactams, 3 to 5 days, based on which regimen that you're using. Another option for uncomplicated urinary tract infections are aminoglycosides. There have been several studies that have shown that a single dose of aminoglycosides have been shown to cause biological cure in those with cystitis. And this study specifically, I believe they use nettlemycin, amikacin, and gentamicin. They were all administered intramuscularly. What they learned was that the concentration remains above therapeutic levels for most uropathogens for 72 hours or longer. So, and we actually use this in the ED a lot, especially if somebody's coming in with a drug-resistant infection, and a lot of times they're referred to ED for, drug-resistant bacteria, but if it is susceptible to an aminoglycoside, it is a very viable option as far as treatment goes. And as you can see here, microbiological cure rates exceed 85%. We're talking about UTIs and urine cultures. This is a very common consult that we get in ID. This is a 83-year-old gentleman who came in for confusion. He was on multiple opioids at home and has come in multiple times over the past several months for confusion. In the ER, he had He was not, he didn't not have fevers, his heart rate was 104, his hemoglobin was 5, hematocrit was 17. So we got a urinalysis on him. The CT abdomen pelvis showed no abnormalities whatsoever. Well, he probably was confused because he wasn't getting enough blood flow to his brain. But, we got a urine culture, and he actually ended up getting treatment for his UTI, though there's no objective evidence that the gentleman had urinary tract infection. So, and I read a study recently that said that, one of the most common reasons why the elderly folks get started on antibiotics for UTIs is because they present with confusion. And studies actually have shown that it is very, very rare that these folks have urinary tract infections. When you're talking about somebody who is living in a nursing home, who has Parkinson's, who has underlying dementia, you will have periods of confusion, and that is the nature of the beast, unfortunately. But not everyone has urinary tract infection, so just be mindful of that when you are considering a UTI diagnosis in someone like this. Got a lot of evidence for that, for treating complicated and uncomplicated UTI. Vaginal estrogen is also something that just wanted to discuss here very quickly. In 2019, the AUA, American Urological Association, recommended vaginal estrogen therapy to peri and postmenopausal women with recurrent UTIs to reduce their risk. And as you can see here, women over 55 with recurrent UTIs, hospitalization was much lower in vaginal estrogen population. Sepsis is much lower. Mortality was much lower as well. So it's just something to consider. If I know that there's questions about like if they've had cancer and if they have had hormonal receptors positive, et cetera, if it is safe. But I think it's just something, if you can have a multidisciplinary approach with UroGYN and GYN to consider vaginal estrogen in your postmenopausal females to decrease the risk of UTIs, mortality. So if you want to know if you have questions regarding duration of antibiotic therapy, we do have a antibiotic duration guide for common infections. If you go on Epic, it's on the side. You go to antibiotic guidance, then you go to antibiotic duration for common infections, and you'll see a summary page, and then further and more detailed pages following that. So me to my gut bacteria while taking an antibiotic. Some of you may die, but that's a sacrifice I'm willing to make. But this, as ID folks and stewardship and lab, we all would like to say that if your patient presents with diarrhea and you have a very high suspicion for C. diff, please order the C. diff test on admission and ensure that the specimen is sent in a timely manner without delay. I think I recently had a patient who was, who's on IV antibiotics. Outpatient came in with nausea, vomiting, diarrhea. CT abdomen pelvis showed a colitis, actually perirectal colitis, and no specimen was ordered at that time for C. diff. And 7 days later, she remained with diarrhea, and of course, she had a C. diff diagnosis, which was probably present on admission as well. So now we will be flagged as hospital-acquired infection versus a community-acquired infection. So just a FYI to you. I think you have survived my presentation.
All right, so I'm going to cover oral versus intravenous antimicrobial therapy. So at ID Week, probably half the presentations that I went to seemed to touch on this in some aspect. So I'm gonna sort of cover some landmark trials, some of that set the foundation for this, as well as sort of highlight some areas that we might have some opportunity. So the graph on the left is a pharmacokinetic chart, sort of highlighting what it looks like when, as far as serum concentrations go, to give a IV antimicrobial compared to oral antimicrobial. Now, in this case, the oral antimicrobial is very well absorbed, so we have to make sure that is the case. The selection of agent is very important here. Some of our oral agents undergo first-pass metabolism, so they get metabolized in the liver and eliminated and never see the bloodstream, so decreasing their actual availability in the serum. But if you look at the IV, you get very quick, high concentrations. It's always 100% bioavailable because we're injecting it straight into the vein, and there's less interpatient variability. So there is definitely a role for IV antibiotics if your patient is critically ill or unstable. However, if your patient is stable and they have gut integrity, oral antibiotics do have advantages as well. They're generally considered safer, easier to administer, and more cost-effective. Essentially, they're associated with shorter lengths of stay. We don't need healthcare professionals to administer them, so there's definitely a opportunity to serve our patients. But we've sort of had a dogma that persisted for years and years that IV antibiotics are better than oral antibiotics. And I was surprised to sort of learn the history of this. I haven't been practicing since the 40s and 60s, so this is something I learned recently as well. But back in the 40s and 50s, they basically published some case series, not randomized control trials, but case series of oral sulfanilamide, oral penicillin salts that were not really the oral penicillin salts that we have today, as well as chloramphenicol. And these case series showed cure rates with oral antibiotics in the sort of 20 to 50% range. When they compared that to IM penicillin, we had 80% cure rates for meningitis, endocarditis, osteo. So that sort of started where, oral didn't look so hot at this case. Now, these oral antibiotics were not well absorbed. They were like 20 to 40% bioavailable. So we were not getting the entire drug we were taking by mouth into our system. In the 60s and 70s, there was case series published with oral tetracyclines and erythromycin for pyelo and severe staph infections, which we wouldn't use macrolides for severe staph infections today, would we? No. But they were tested this way against IV antibiotics, and they didn't perform very well. But basically, these case series were accumulated and published by very respected authors in review articles, and basically touted the advantage and superiority of IV therapy. This persisted up until sort of the 2010s, and we started sort of questioning the data and re-examined everything. And then we set up some randomized control trials, and they were finally published, and sort of the foundational ones were kind of published in 2019. And we'll sort of review a few of them. Not all of them, but a few of them. But before I go into these trials, there's some common themes with these trials. So I want to make sure that you understand that when we say that IV is equivalent to PO, there's certain factors that come into play. So these patients had either sort of were clinically stable, or they were moving towards clinical stability. So they weren't on vasopressors. Their fever curve were like they were improving. Their white counts were improving. They were careful in selection of their oral antimicrobials. They chose highly bioavailable agents. They confirmed that the organism was susceptible to the agent prior to putting them on oral therapy. These patients had a functional GI tract, so they were able to swallow. They were going to absorb the drug if we gave it to them, and then they were going to have compliance. So if we look at our oral agents, our oral antibiotic agents, those in the green, we can expect, if we have gut integrity, that over 80% of the drug is going to be absorbed. So these are our quinolones. This is Bactrim, linezolid, Flagyl, our tetracyclines. But it does include some of our oral beta-lactams. Cephalexin, cefadroxil are approaching 90% absorption rates. Amoxicillin is up above 80%. Rifampin, What's not included here is some of our third-generation cephalosporins like ceftonir, which only obtains 30 to 40% oral absorption. Cefidoxium is right about 50%. Our macrolides aren't really that well orally absorbed, but they've been proven effective, so we do switch those from IV to PO automatically. But this is not an all-encompassing list, but just sort of to give you a picture, when I talk about these studies, it's the highly bioavailable agents that are more than 80% absorbed that we're talking about being used in these studies. So the first study I'll sort of lay out is the early switch trial for uncomplicated gram-negative bacteremia. So the majority of these patients, we're talking about complicated urinary tract infections. On day 4, they were randomized to either be switched to oral therapy or stay with IV. We now know, thanks to Dr. Varghese, that our standard duration for this would be about 7 days. So about a little over 400 patients in each group. The non-inferiority margin was about 6%. The endpoint was 90 days all-cause mortality. Oral therapy had an all-cause mortality of about 9.1%. IV had an all-cause mortality of about 11.7%. So if we look at the antibiotics that were used here, oral beta-lactams were the choice here. So a lot of Keflex, a lot of amoxicillin, and 60% of the patients got oral beta-lactams. About 15% of the patients got Cipro, and then after that, the next most common was Bactrim. So we're choosing highly bioavailable agents. We'll switch over to orthopedic infections. Now these were fairly serious orthopedic infections. These were prosthetic joint infections. They actually excluded mild osteomyelitis. They also excluded concomitant endocarditis and CNS infections. But in general, they were real orthopedic infections. After surgery, within 7 days, they were selected to be on an oral antibiotic or stay on IV, or if they didn't require surgery before 7 days of antibiotics, they were switched to an oral option. Non-inferiority margin was about 7.5%. They looked at treatment failure at 1 year. Numerically, everything kind of favored the oral approach in the intention to treat group and the modified intention to treat group, as well as the per protocol population. And what was really interesting is they did a worst case sensitivity analysis where they assumed all the missing data was unfavorable for oral and favorable for intravenous therapy, and it still met non-inferiority even though they assumed the worst outcomes. So if you look at secondary endpoints, early discontinuation was actually more common in the IV group. IV catheter complications, as you would suspect, in the IV group was about 1 out of 10. In the oral group, it was only about 1 out of 100. Length of stay was shorter after randomization. It was about 14 days for the IV group and 11 days for the oral group. And again, they left it up to the provider to choose oral therapy to switch to. Quinolones were the most common. Beta-lactams, clindamycin, tetracyclines were also chosen. They didn't really make it real clear, but a lot of times this was combined with rifampin. And then if they couldn't use rifampin, they chose to use a combination, of one of these, quinolones with a tetracycline or et cetera. And then we'll switch over to the third trial I'll mention is the POET trial. This was left-sided endocarditis, 6 weeks of oral or IV. They got at least 10 days of IV therapy up front, and then after that, they were able to be switched to oral or after that. Non-inferiority margin was 10%, about 200 patients in each group. They did a 6-month composite endpoint. That composite endpoint included all-cause mortality, unplanned cardiac surgery, embolic events, or relapse in bacteremia. In the IV group, that composite endpoint happened 12.1% of the time versus 9% in the PO group. So the non-inferiority margin was definitely met. When they looked at all the endpoints individually, no endpoint stood out as being any different from in either group. What was interesting is they felt that the 6-month composite endpoint might not have been long enough to look at things. So they did a 5-year follow-up on this study that was published in 2022. And they saw that the composite endpoint happened in 45% in the IV group and only 33% in the PO group. So the hazard ratio actually favored the oral therapy. And what I forgot to mention was that the length of stay in the oral group was actually about half of the IV group. So after randomization, the IV antibiotic group stayed in the hospital about 19 days, while the patients that were switched over to oral antibiotics only stayed in the hospital 3 more days and were out. So roughly, they get out of the hospital 2 weeks sooner, and that's what they link this, this outcome to, is like, it's just beneficial to get patients out of the hospital sooner, and oral antibiotics help us do that. When they did the breakdown of the composite endpoint, the only endpoint that was any different from each other was the all-cause mortality endpoint. And that actually favored the oral therapy group of 23% versus 35% in the IV group. So it was really attributed to sort of oral therapy getting patients out of the hospital sooner for them to do better. I highlighted 3 trials. There's over 50 now. Over 7,500 patients in those trials: osteomyelitis, endocarditis, bacteremia, pneumonia, intra-abdominal infection, UTIs. There's not one single randomized control trial that says IV therapy is better than oral therapy. But what do our patients think about it? So this was a small survey of patients who underwent treatment for Staph aureus bacteremia. They surveyed the survivors. But basically, they got IV therapy during hospitalization, and then at some point after discharge, they were switched to PO. They did the survey to sort of figure out, well, how convenient were your antibiotics? What effect did the antibiotics have in your day-to-day life? Do you feel the antibiotics were working or likely to work? And what do you think is stronger? Was it the IV therapy or the oral? And which did you prefer, the IV or the oral? Overall, everybody, most of the patients preferred PO therapy. Only 11% preferred IV. Those who preferred IV felt like they just liked that they were sure they were getting the antibiotic. They didn't feel that they could be compliant with the PO. But overwhelmingly, everybody preferred PO. 88% felt PO was more convenient. 71% perceived IV as faster, stronger, or more effective. But 35% had heightened anxiety with IV, and 53% reported sleep disturbances. So overwhelmingly, our patients prefer PO. So just to look under at our processes here, we have a automatic IV to PO conversion policy that we run through the pharmacy. We only look at select agents, and we keep the same agent, we just switch it from IV to PO. So that patient on IV ceftriaxone that could be put on oral Keflex or switched to oral Cipro, we don't even look at those patients. We look at switching oral IV Cipro to oral Cipro. You have to meet certain criteria. You have to have at least 48 hours of IV antibiotic therapy, adequate GI function, taking other oral medications. You have to maintain blood pressure without vasopressor therapy. You have to be afebrile for 24 hours, and your white blood cell count has to be trending towards normal. All those criteria have to be met before we switch to our IV therapy to PO. But I feel like we have a lot more opportunity to do so. This is some of the data I pulled from Epic. On those agents, those very select agents that we deem as being able to switch IV to PO as soon as the patient is stable, if we just look at those agents, 60 to 70% of those agents are still given IV across the board. I don't know where we should be. I have a feeling it should be closer to 50-50 or maybe either more favorable towards oral therapy. So in summary, the highly bioavailable oral antibiotics are equally effective as IV. The bacteria doesn't seem to know the difference whether we give it by mouth or by IV. And I guess one of the things I want to drive home is the route doesn't matter, but choosing the right agent does. We want to choose the highly bioavailable agent. Oral antibiotics are safer, more cost-effective, and decreased length of stay, and our patients overwhelmingly prefer them. And in most stable patients, oral antibiotics probably should be the standard of care. And that's all I got.
Thank you. Those were great presentations. We have 12 minutes, and I don't know how detailed I can get into the studies, but what I'm trying to do is maybe highlight some articles. Hopefully you'll go and review in detail later. So this one is actually from the Journal of Applied Laboratory Medicine, and they really talk about the multiplex PCR panels. And it's a great review article, and it goes into the details of how these are great tools for us to have, but then they come with multiple problems if we don't use them on the right patients and if we don't know how to interpret them. And a recent case actually I was sharing with ID team, and Barry just now, is a patient with strep pyogenes toxic shock syndrome, had enteropathogenic E. coli in the stool. And that was being attributed as playing a role in the toxic shock when we have the bug, which is strep pyogenes, causing the toxic shock from probably a left-hand necrotizing infection. And if you look at the pathogens listed in the panel, these are all community-based pathogens. These are acquired in the community. But we often see these are being ordered in patients who've been in the hospital for a week, 10 days. And these are not inexpensive. They run into hundreds of dollars. And we see these tests being repeated multiple times, ordered when it's not indicated, and ordered when these patients have been in the hospital longer, where they're not really testing for those hospital-acquired pathogens. So again, I really encourage you to go and look into this article. It's a great review article, how you can leverage these tests to help you and your patients, but not order them when they are not clinically indicated. One thing we do here is we do suppress C. diff in the panel for the GI, but we still have a lot of opportunity where we're not ordering this test in those more than 72 hours, hopefully to leverage EPIC. Also to ensure that we're asking some questions or hard stops or soft stops to guide appropriate ordering. And of course, we should know how to interpret. Same thing goes, and this for the meningitis encephalitis PCR panel. And if you look at the pathogens that are listed here, again, they're all community acquired. But we often see this test being ordered in patients who have had neurosurgical procedures. It's not looking for MRSA, Staph aureus, those bacteria that you're looking for, Pseudomonas, so this really is not a test. Again, this review article really goes into the details of who are that intended patient population that you should be using the ME panel, when you should be ordering it, and really talks about guiding us. And what I really liked about this algorithm from the Mayo Clinic is really talks about differentiating healthy patients from those who are immunocompromised, that we really don't need these expansive panels. If our patient is healthy and we are clinically looking for, we could just order a dedicated HSV PCR, culture, the strep antigen, we don't, and if those are negative, maybe then add on these expensive panels. So again, we're hoping that we can implement something like that here, but now we have a lot of discussion going on about diagnostic stewardship and promoting appropriate testing. So this was a really great review article that I highlighted at ID Week that I'm bringing up, and this is actually straight from one of the health systems that were successful in implementing that when we actually see a patient and we're doing an LP, that we're not really even waiting for the cell count or anything from the CSF analysis, we're ordering the ME panel at the same time. I think at least the minimum we should be looking to see if they have more than 10 WBC in the CSF. We have a suspicion for infection. This is not a post-neurosurgical patient before we order the ME panel. So they have been successful in decreasing the utilization of the CSF ME panel by implementing something like this in their EMR. And we are discussing with our neurology leadership to see what we can do here as well. So at least until then, we have a EPIC solution. Hopefully that you will use your critical thinking to see if you have a suspicion for CNS infection, community acquired, does the patient have more than 10 WBC in the CSF, not a neurosurgery infection, post-surgical infection patient before you actually order the ME panel. And something else, this was something I saw in one of the talks at ID Week, was about when a provider goes in to order any of the STI testing, they actually have a prompt to ask if you want to test for HIV. I think that's something really good, that if something that maybe we can leverage here, if this is not a known HIV patient. So I think these reminders are very helpful. So again, just something I thought was interesting. And of course, procalcitonin. This has been something we recently reviewed at our stewardship committee as well, but I want to highlight a couple of studies here related to procalcitonin. This one was done at the Mayo Health System across their enterprise. The objective was to retrospectively observe procalcitonin and antibiotic ordering practices in patients hospitalized with community-acquired pneumonia. This was a retrospective, exact matched multi-center cohort study between 2018 to 2023. And what they really wanted to see was if using procalcitonin helped decrease the duration of antibiotics, length of stay, or days of an antibiotic therapy. And what they found was that actually that didn't really help, that the use of procalcitonin in patients with CAP was not associated with decreased length of stay or decreased 30-day mortality, decreased days on therapy, or decreased treatment duration. This is in adults. And this was another study that was done in UK, batch trial, where they looked at children 72 hours of age to 18 years, again, trying to see if procalcitonin really helped in guiding the antibiotic therapy. So what they included anyone who was admitted with a suspicion or confirmation of infection and were expected to be on antibiotics for 48 hours or longer. Again, was conducted between 2018 to 2022, and they looked at whether they got the usual standard of care or they got procalcitonin guided algorithm based care. And what they noted was that the minimal duration of antibiotics in the procalcitonin group was 96 hours and in the non-procalcitonin group was 99.7 hours. And they concluded that introducing the procalcitonin guided algorithm did not really decrease the duration of IV antibiotic treatment and was non-inferior to usual care. And there have been some health systems that have been very successful in implementing procalcitonin guidelines. There's some that have restricted its use for those 90 days or younger age group only because it's still part of their sepsis workup guidelines. But again, this was presented at ID Week, and I thought this guideline was very helpful. We are in discussions with our ED colleagues. We are also reviewing this at our various committees as well, because one of the things we're observing is that the procalcitonin, instead of decreasing antibiotic utilization, actually is leading to increased antibiotic use. And this one, I would caution, that I almost hesitated whether I should even mention this trial or not, but I thought I should, because if you just do not get into the details, it appears like the procalcitonin helped actually decrease the antibiotic duration. But if you really go into the details, this study was done in UK across 41 ICUs under the NHS service and was conducted between 2018 to 2024. And patients here were assigned to either procalcitonin guided protocol or CRP guided protocol. The CRP one was really inconclusive, but just focusing on the procalcitonin, the mean antibiotic duration for the procalcitonin group was 9.8 days, and the non-procalcitonin group was 10.7 days. But if you really look at the mortality, the procalcitonin group had a mortality of 20.9, which is higher than the one in the non-procalcitonin group, 19.4%, 28-day all-cause mortality. That was not statistically significant, but I don't think the intent behind shorter durations for us, especially if you're using procalcitonin, is to have that higher mortality. So at least this study, I was not too impressed with it, but I really encourage you to review and see what conclusion you would come to. And this was another one at ID Week I thought was very interesting. The Take 5 campaign, where they really at 2 urgent cares, they implemented this multifaceted intervention to promote 5 days of therapy for some of the common infectious scenarios they would see, like skin and soft tissue, cystitis, UTIs, pneumonia, sinusitis. I mean, they had flyers, they had educational seminars, they created scorecards to providers, compared them to their peers, and they saw that from just around 50% usage of the shorter duration, they were able to increase that to 82% among their providers. This is something in the ambulatory stewardship group we're hoping to see what we can do here in our community by implementing something like this. This is another study, at least I hope you go and review the details of it. We add azithromycin to every patient that we are admitting with community-acquired pneumonia. That is our guidelines now. But if you look at the strep pneumo resistance in our community, only, I think, 35% or 35 to 40% are susceptible. Majority are resistant. How much is it really helping? And if you look at this particular study again from the Journal of Infectious Diseases, where they actually analyzed EHR data from almost more than 8,000 adults hospitalized with CAP, again done at UK. The backbone was either amox or amoxiclav, and they looked at patients who got macrolide versus who did not get the macrolide, and they concluded that addition of macrolide was not associated with improved clinical outcomes for the patients with CAP. So again, brings us to question our standard practices. There have been some health systems that have implemented alerts to justify azithromycin. Again, something to consider for us. This was one of my takeaways from the ID week. And of course, with what we do in infection control, I could not help but add a couple of studies from AGIC about the awareness of peripheral IV catheters. I really, really request you all when you're seeing patients to please look at the peripheral IV sites. This is one study where they highlighted that nurses were more aware of their patients having peripheral IV catheters than providers. And if I'm not mistaken, let me get the exact number, only 30% of providers could even vouch for the exact location of the peripheral IV. So again, very, very important for us to be looking at those sites to see if any signs of phlebitis, remove them if they are not needed. Not every hospitalized patient needs a peripheral IV. So again, look at the need for that and review daily necessity. And remove any lines that are placed in the field immediately, because we don't know, most likely they have not been placed in aseptic precautions. This was another poster from ID Week I thought was very, I was very impressed with what they did. They looked at complications from peripheral IV. They are not benign. We talk about CLABSIs and CLABSI-related complications. And here, there are patients that ended up with endocarditis, fasciitis, myositis, and CNS involvement. So they reviewed the complications just from peripheral IV-related bloodstream infection, leading to more invasive procedures, increased length of stay, increased antibiotics, mortality. And this is something I hope, and that's something, one of my takeaways from ID Week was, can we create a peripheral IV harm report? Can we have a standard way of collecting that data, seeing how we are doing in terms of how we care for peripheral IVs here in our patient population? So this was another takeaway for me. And something in the process of implementing is nasal decolonization for MRSA for patients in the ICUs. This is again another paper that was presented at the ID Week about how implementation of a nasal decolonization helped decrease MRSA rates. And this is something we're in the process of piloting. That's all we have, and it's 1:01, so we finished almost on time, 1 minute excess. Thank you for attending, and we'll be here if you have any questions. Thank you.
Thank you so much, Dr. Mannepalli. If anybody has a question for any of our speakers today, please raise your hand and I will bring the microphone to you. As a reminder for anybody watching online, please post your question in the Q&A and we'll read it aloud. Do we have any hands up? We have a question, all right.
Hi, it's wonderful. So I'm Bill, I'm the microbiology supervisor here in the lab. I had a question about the changed guidelines for complicated versus uncomplicated UTI. Will those same breakpoints just be kind of, you'll use that guideline to infer then the treatment based off of the current breakpoints?
Breakpoints for the antibiotics?
Yeah, so looking at complicated versus uncomplicated UTI, now we're defining that differently, right?
Uh-huh.
And so the CLSI definition of what is susceptible for an uncomplicated UTI is going to remain the same, and you'll just interpret the patient differently? Is that how that works?
So, if I understand your question correctly, you're talking about the antibiotic choices themselves, right? If it's like updated based on the most recent CLSI guidelines?
Yeah, so when you're looking at the breakpoints for CLSI, can you hear me okay up there?
Yeah.
Okay, so when you're looking at the breakpoints, it says for this particular drug, for an uncomplicated UTI, this is what you're looking at as far as the interpretation. Since the definition of what is uncomplicated versus what is complicated is now different. Is that just you're going to use those same definitions, the IDSA definitions, to?
I don't think,
Yeah, I don't know if I understand your question correctly. I think for lab, though, what you're reporting is based on the site, right? And then we, with our clinical information, we're going to kind of classify whether it's complicated or uncomplicated. Would CLI site change anything? I don't know.
yeah, I don't know the answer to that.
Yeah.
I don't think it really matters, though,
Yeah,
Bill.
from a lab side, because, yeah.
From a lab standpoint, it doesn't matter. Because like for us, if it is complicated, we want to ensure that we're choosing a regimen that is, appropriate for, like if there is bloodstream infection that's appropriate with bioavailability.